You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast, and I have Wermter. I guess another pronunciation is Wermter, if you're German. And we are talking about sleep technology and sleep trends, and Ellen's a board-certified family nurse practitioner. So thanks for coming, Ellen. How are you doing?
Thank you for having me. Doing great.
Yeah. Well, tell me about your work as it interfaces with sleep. What do you do?
I work in a sleep clinic, a sleep medicine clinic in Charlottesville, Virginia with Dr. Chris Winter. And I see a variety of sleep disorders here, sleep apnea, insomnia, and also narcolepsy.
And out of the conditions, are there ones that seem to be more prevalent, especially lately, or are they just more prevalent than people think? Like, what is your overall observation from working there?
There is a lot of sleep apnea. I would say that's probably the majority of our patients. Insomnia tends to crop up as well, although a lot of that can be treated in primary care, and we kind of get the harder cases of insomnia. Restless legs, fairly common. Again, that's something that can be managed in primary care as well, but we also manage it here at the sleep clinic. And then narcolepsy is actually, it's considered rare, but it's underrecognized. So there's a good bit of it out there.
Yeah, I think I know it's a serious thing, but I know people make fun of narcolepsy, like in the movies and stuff like that. And
exactly, I think that's.
Well, let's talk about narcolepsy just for a few minutes. Is it like in the movies? Are you talking to someone and all of a sudden the person falls asleep, or what is narcolepsy actually like?
Exactly. That's such a good point. Is that I think there's not a lot of good press. There aren't a lot of good depictions of what narcolepsy is actually like for people, and what living with narcolepsy is actually like, and that's why it can be difficult to recognize. And unfortunately, in some of the things that you see in TV or hear about, it becomes almost a joke. It's actually a pretty significant chronic neurological disorder that affects the brain's ability to control sleep-wake cycles. So there's this instability between sleep and wake where they can't control very well their ability to stay awake. And it's not really a choice for them, which is the difficult part. In fact, most patients with narcolepsy are very frustrated by their inability to, maintain their wakefulness. It's very, very difficult disease to live with. When I think about sort of what it looks like, most of us, have you ever been, driving in the city at night and you see a building and most of the lights are off, but there's like those six different, offices that left their light on that night, and so you see those six ones lit up. Yeah, so with a regular office building, you think of it as, during the day everybody shows up to work, all the lights go on, and they're awake for the day. So the office building is like your brain. The more lights that are on, the more alert and awake you are. The more lights go off, the more sleepy you are. And in a normal person, lights on during the day, lights off at night. And a patient with narcolepsy, I picture that building as having sort of rolling blackouts. There are just times when they're not getting the electricity. Floors 4 through 12 just completely black out. And that person is super, super sleepy. And not a lot's going to help other than sometimes napping. will increase that, or medications, which is our sort of role in this, is to help manage through medications and other lifestyle changes. But what this person looks like, when they present to us, is excessive daytime sleepiness is your main sort of presenting feature. So having difficulty staying awake during the day. So it's not the falling over at all. It's more of that excessive daytime sleepiness that is the main presentation.
Are there different levels of narcolepsy? Some more severe than others, and what do you do to treat someone?
Yeah, so there's two types. There's type 1, which is with cataplexy, and type 2 that's without cataplexy. And different people also have different levels of daytime sleepiness. So some people are going to be sort of managing a little bit better than others. Certain things make that worse, like stress. Cataplexy is probably where, the falling over, where we get that image. And what that is when people have a strong emotion, they'll have a sudden weakening of their muscles. So their knees might buckle, or maybe they drop things because their grip gets loose. It can be dramatic, but it can also be pretty subtle, where their jaw will get kind of slack or their eye will droop. And what's happening there is that sleep-wake instability, again, where they're going into they're having an intrusion of REM sleep into their day. So during REM sleep, which is what we think of as our dream sleep, our major muscle groups are paralyzed. And so what they're getting is that paralysis from the REM sleep while they're still actually awake. So they might be, at a party talking to friends, somebody tells a really funny joke, they crack up, and then all of a sudden they drop their glass because their arm completely lost muscle tone. During these instances, they're completely conscious. So if they have a bad episode where their knees buckle and they fall, they can't move their body at all, but they're completely aware that they're falling the whole time. They're not passing out. It's not that kind of situation. So it can be significantly impact your life if that's happening to you on a regular basis. Other symptoms, you can get really disrupted nighttime sleep. So even though we think patients with narcolepsy, man, they sleep all the time, they're always sleepy, their night sleep isn't that great. So again, it's that office building with lights coming on in the middle of the night, and they're not supposed to, sort of the opposite of the rolling blackouts, You can also get sleep paralysis, where when you're waking up or falling asleep, you get that paralysis where you want to move your body and you can't. And often you have very vivid dreams that feel very real, and they can be accompanied by some hallucinations, like you think you hear someone in the room, or you think you hear someone calling your name, or something like that. Those are hallucinations that can come as you're going in and out of sleep, and that's that intrusion of REM.
That's horrible. I mean, where does narcolepsy come from? Is it a genetic thing? Is it, are there life conditions or stress that can put you into this state, or how does it happen?
Yeah, a little bit of both. So it does tend to run in families. We're pretty sure that there's an immune system component to it. They did a study this year that showed that their T cells, which is an immune cell, is more responsive to a specific neuron that makes orexin. And orexin is a neuropeptide that helps to stabilize the sleep-wake cycle. So there's a deficiency there because your immune cells attack the neurons that make that neuropeptide, so you just don't have enough of it. An environmental trigger is often involved as well. So we see clusters of narcolepsy following certain environmental situations, like when we had H1N1, we saw a spike in narcolepsy after that particular strain of flu, some strep strains as well. So we think that possibly, you have this response to, this environmental trigger, or this, thing that's happening, and then your immune system erroneously attacks those neurons that make the orexin, and then then now you have difficulty regulating your sleep-wake cycle. There is also human leukocyte antigen. It's a gene that's important in regulating the immune system, and variations in that gene can be found in people with narcolepsy that increase your susceptibility to developing it, but it's not always there. Some people might not have that gene but still end up with narcolepsy. Sometimes, trauma can damage that part of the brain that makes the orexin and can cause we think can cause narcolepsy as well. Mm-hmm.
So what are some treatments for narcolepsy? What can you do?
So treatments, they're crude, but they're getting better all the time. So we're always looking for more tools in our toolbox so that we can, have a better way to treat them. I think as a clinician, we have to constantly be reassessing the efficacy of what we're using for our patients, because we can put them on a medication that helps them go from extremely sleepy to less sleepy, but less sleepy still may be far above sort of normal sleepiness level. So it's like we're giving them a prescription for eyeglasses and they're like, oh, this is great. I can see the mailbox at the end of the street. And we're like, okay, that's awesome, but we want you to see the house across the street, or we want you to see the mountains in the distance. So we're constantly trying to find, options that really get them, to a better level of wakefulness during the day. Most of the time we're starting with some sort of stimulant to wake them up during the day. So there's a couple of different medications. And I should say, regarding medications, these are all my own opinions and clinical impressions. I'm not speaking on behalf of any companies here, but we'll start with a stimulant specifically for narcolepsy. Sometimes we have to use a standard stimulant like you would use to treat ADHD or something like that. There's also a medication called sodium oxybate that helps patients to go into a deeper sleep at night so that they have less disturbed nighttime sleep and can make as much of that orexin as possible. That can be a game changer for patients, really, really effective medication. We also work with them with lifestyle changes, any tweaking that good sleep hygiene, having a regular schedule, exercising, good diet, scheduling their naps, watching their caffeine and alcohol. That's all important too. And one of the newer treatments that's become available to us in the last 6 months is something called the PEACE program, which is Pitolisant Expanded Access Clinical Evaluation Program. And what that is Pitolisant is a medication that's been available in Europe since March of 2016. It's an investigational drug in the United States, so it has not yet been approved by the FDA, but because they've seen good results with it in Europe, it's been approved for this breakthrough program. And so they've set up this program here so that patients that they think may benefit from it can get access to it. So our clinic got trained to administer this medication, and we've signed some patients up and are able to get this medication for them. And what's different about it is that it goes through a different system. So it uses histamine, and histamine is an alerting neurotransmitter, which also projects to other drivers of wakefulness, to dopamine, norepinephrine, serotonin, those types of things, and possibly the REM neuron centers as well. So trying to, people take antihistamine like Benadryl, it makes them sleepy. So this is kind of the opposite. We're trying to increase the availability of histamine to try to be a stand-in for orexin to help stabilize sleep-wake.
Interesting. Huh.
Mm-hmm.
I've heard, I guess, modafinil, I don't know, maybe it was an old drug or a new drug. Isn't that supposed to help with narcolepsy as well?
Yes, and that's when I was speaking about, kind of first line, what we start with a lot of times with patients is we put them on either modafinil or armodafinil. And those have been fantastically helpful as far as bringing down that excessive daytime sleepiness a few notches. And when we've added this pitolisant drug, we're usually keeping them on their current medication regimen. So most of these patients are already on modafinil or armodafinil. They may also be on Adderall or Ritalin, and they may also be on the sodium oxybate at night. But then we're going to add in the pitolisant to see if hitting it from another direction is helpful for them. And we've had a pretty good response from it in our clinic. There's roughly 28 clinics in the U.S. that are administering it. In our clinic, we have about 36 patients enrolled. And I would say of those, really good response from probably a third, like very, very favorable response. I would say another third, maybe enough of a response to remain on it. And then I have about a quarter or so that are still kind of on the fence. The other third, I would say, maybe on the fence. I have had a few that have discontinued it for, either didn't stay with follow-up or didn't have a great response and had some mild side effects and decided not to continue it. But anytime you get, a really good response out of something, I think it's with narcolepsy patients in particular, we have so few things that we can try that it's always worth a shot to see if we're going to see a marked difference or not. So I had a patient, come and say, I've wanted to get this project done for 8 months. And when this medication kicked in, I took a day and I knocked it out, and I never would have been able to do that. I've had a mother call to thank us because her son was, actually came home from work and was able to make her dinner instead of just going straight to sleep. So those are quality of life, changes. And we see those with some of the other medications as well. But like I said, to be able to add it and get, tweak their regimen even higher has been fantastic.
Well, how do you know if someone's, I don't know, they're just feeling off or they're having problems? How do they know if they have narcolepsy or if they have this, that, or the other? I mean, what do they do?
Yeah, well, diagnosis is super interesting because it is underrecognized and underdiagnosed. It's 1 out of every 2,000 Americans. We think about 3 million people worldwide have narcolepsy, but we think 50% of patients with narcolepsy we haven't found it in them yet. So usually the typical onset is between, in young adulthood. Oftentimes it can be young, very young, like 7, 8. But usually it's showing up around high school, college, particularly when there's more demands where you can't get away with sleeping extra anymore because you have to be there to show up to your class or to take your exams and things like that. On average, patients have 6 physician visits before receiving a narcolepsy diagnosis, and there's a 5 to 10 year delay in getting the diagnosis. Often they're misdiagnosed with other things first. So I have a lot of patients that come and say, oh my gosh, I'm just so happy I finally figured this out. I've gone to all these different things. I've had every blood work done and under the sun, and I knew something wasn't right. I just didn't know what. So, thankfully, eventually, usually somebody ends up in the sleep clinic and we have them undergo a special kind of sleep study. They stay during the night to rule out any other sleep disorders, because if you had really severe sleep apnea, you could fall asleep pretty easily during the day too. So we rule out that with a nighttime study, and then they stay for an MSLT, which is a multiple sleep latency test, where every 2 hours they put you down for a nap, and we see how quickly you fall asleep and if you go into dream sleep during that nap. So really interesting. I will say about the MSLT, I'm glad we have something to help us with diagnosis. It's not a perfect test, and sometimes patients go to a sleep doctor and they have an MSLT. It doesn't confirm the diagnosis of narcolepsy. Let's say they only fall asleep or they only have a REM onset period, which is a dream, in one of their naps, and you need 2 to meet the criteria. That doesn't mean they don't have narcolepsy. It means that in that particular instance of that picture of that day, we couldn't confirm it. So I think sometimes people are sent away like, no, you didn't have two dreams, so you're done. You don't have narcolepsy. It's more important to kind of look at the total clinical picture, and sometimes, to repeat that MSLT or to treat them with what, we can make a clinical diagnosis if we need to. So I would encourage people, if they've been told that, but they were really borderline, that they might want to, see someone else about it or consider doing a repeat study.
Well, what kind of things do people come to the clinic that they complain about, and are they usually on the right track, or are they surprised? Like, I didn't think I had narcolepsy. I thought I was just tired, or I didn't think I had
Yeah,
this. I thought I was just
yeah.
tired.
A lot of them are surprised. Yeah. The ones that aren't usually have somebody in their family or somebody that they know, and so they know a little bit more about it. But, you know, as we were talking about before, it's not something that is described well in movies or literature, or that people talk about a whole lot. And sometimes even when patients with narcolepsy get diagnosed and they're so relieved and they want to go out and tell everybody, guess what? I found the answer to my problem. I have narcolepsy. Nobody understands that. So one thing that I make sure I do with my new diagnosis patients is talk to them about joining up with a support group online of other people with narcolepsy, because they're really the only people that are going to understand what they're going through. But people usually come in with excessive daytime sleepiness that we haven't found a solution to. Like, they've checked their thyroid and they've made sure they don't have Lyme disease, and they checked their iron to make sure they're not anemic, and they've done all these things and they're still sleepy. And then when we question them further, you ever have this happen, or you ever have sleep paralysis? All of a sudden they're like, yeah, that does happen to me. I thought that happened to everybody. I thought that was normal. Well, there are a certain number of people that have sleep paralysis and don't have narcolepsy, but it's also a symptom. It's a little clue that something else might be going on.
And, it may sound totally obvious, but what is excessive daytime sleepiness? Does that mean like you're just tired all day long? Does that mean that you're tired, you take a nap, you wake up, you're still tired? Like, what are
Yeah, that's a good
people tell you?
question. So there's something we use in our sleep clinic called the Epworth Sleepiness Scale, and it's a series of questions that say that basically how likely would you be to fall asleep in each of these situations. So I would say to you, if you had an opportunity to nap in the afternoon, how likely would it be that you'd fall asleep? To lie down and rest in the afternoon, rather? So you have this opportunity to lie down and rest in the afternoon. Would you for sure fall asleep? Pretty likely. Would it be a 50-50 chance? Would it be a slight chance? Or is there no chance you would fall asleep? So you give me the answer. I write down the corresponding number to that, and then we go through the other ones, basically talking to someone, watching a TV show, reading a book, sitting quietly after a meal, sitting in a waiting room or a lecture, things like that, riding in a car for an hour without a break, those types of things. We add those numbers up. A normal amount of sleepiness would be a score of under 10. 10 and above is called excessive daytime sleepiness. Most people with narcolepsy are scoring in the teens, pretty high up on the excessive daytime sleepiness scale. And it's a good way to kind of, flesh out true sleepiness from fatigue, which you get fatigue. Fatigue is more, I'm running a marathon and I'm so exhausted. It's not, I want to lie down and sleep. It's, I want to sit down and rest. So it helps to distinguish between those two, and it also helps to have an objective measure. So when they come back, we can do the scale again, and we can see, okay, did you go from a 20 to now you're a 17? Well, 17 is still really sleepy. We'd like to get you down to 9, if possible. Average is about a 6 or 7, yeah.
Okay. Any other complaints people have when they, the common ones, when they come to you and it tends to be something other than what they're complaining about, or they're complaining about something that, that usually means apnea, or that means this, it means that. Like, what do people tell you is bothering them, and then what does that translate to, or what could it translate to?
Well, with sleep apnea, you do see daytime sleepiness, but you also see other things like brain fog is one I hear a lot, which is kind of a general term, but basically what it means is having a hard time with concentration and attention during the day, just feeling kind of foggy and fuzzy. And there are changes in the prefrontal cortex with sleep apnea that happen over time, some thinning there that can cause some of these symptoms. So that's one that's kind of surprising. Nocturia is another one. So people will say, I get up, 4 or 5 times a night to go to the bathroom, and that can mean you have sleep apnea. It's a less common symptom. Usually people with sleep apnea are coming in with their spouses. They're saying they're snoring really loud, and I notice gasping or pauses in the breathing, things like that. But nocturia is kind of a insidious one, but it definitely is there, where if we treat severe sleep apnea, it can get a whole lot better. People will say, I just thought I was getting up that many times to go to the bathroom because I was getting older, or it was my prostate or whatever. And it turns out I went from 4 bathroom visits now down to 0 or 1 because I treated my sleep apnea. So, that's one of the things that people are surprised by. And for narcolepsy, it's usually the main one is the daytime sleepiness. Sometimes the vivid dreams, they can have almost a whole other life in their dream. It can feel so real that it feels almost like they're living 2 different lives, one in their dream life and then their regular life.
Oh, wow.
So, yeah.
Huh. What about the occurrences of the various things you see? So is narcolepsy on the rise or stable? How about sleep apnea, restless leg, and the other common phenomena you experience?
Sleep apnea is on the rise, and some of that's due to obesity. I would say narcolepsy tends to, again, cluster. I think the only reason I would say it's also rising is we're getting a little bit better about diagnosing it. It's getting a little bit more attention, and so the more people that it's on their radar, hopefully people won't have to search quite as long before they, get that diagnosis. Restless legs, I'm not sure. I think that's been pretty stable. I think it's the incidence has been about the same as normal.
Right.
Whereas in the past, rather. And insomnia, insomnia is tricky. That goes back and forth depending on what type of insomnia you're talking about. Everybody has times where they have difficulty, initiating or maintaining sleep. I don't really call that true insomnia. Everybody's going to have a bad night here or there.
Right.
So that one's trickier.
What kind of people come into the sleep lab? Is it all over the place, or do you see certain populations more than others, or are there certain conditions that tend to cluster in certain populations?
Well, we get a fair share of narcolepsy here because we're kind of the last stop for that. And we do see a lot of sleep apnea. Certain doctors are more in tune to it and really look for it and really understand sort of the health benefits of treating it and the risks of not treating it. So certain primary care doctors, but also cardiology, because there's so many different negative cardiovascular effects. It's a lot of wear and tear on your heart to have sleep apnea. So, cardiologists know if they've got a patient that's never been asked about their sleep or about their snoring, that's a low-hanging fruit for them to go get a sleep study and to, see if we can treat that and kind of help things overall. Resistant hypertension too. 80% of people with resistant hypertension have sleep apnea. So if you have somebody, primary care practitioners, if they have somebody where they've tried an ACE inhibitor, they've tried an ARB, they've tried they've gone through 4 different medications, they're upping the dose, and then they're now on these different therapies, and their blood pressure's still uncontrolled. Best thing you can do at that point is send them for a sleep study and make sure that you're not missing that, because that will help to get that resistant hypertension under control.
Yeah, I had a question about sleep studies. So, years ago I was told to go do one, and I sleep very late. For instance, I go to bed like 3 a.m. I just been going to bed at 3 for a long time, and they were like, "Oh, you got to be in here by 8 o'clock, and you need to be asleep at 9, and we'll kick you out at 6 a.m. And I thought, how's that going to work? I'm not in my environment with my pillows in my bed, completely different times than I normally go to sleep. So do you run into that, or is it people come in and it works just fine to do the sleep study, or do they say, I can't sleep in this place? Or, what's it like for people that have to come in and do that?
Yeah, sleep studies are tough because most people are going to have what's called a first night effect. I mean, you go camping and you hear every little cricket and every rustle of the leaves or everything. And your first night camping, you're not going to sleep. You're going to sleep pretty terribly, but you rebound the next night because now your brain knows, okay, I'm camping. I hear the rustle of the leaves. I hear the river going by. This is all normal. So we have this hypervigilance when we're in a place where we're not familiar with already, that's sort of interfering with our ability to sleep. And then what you're talking about is you already have sort of this delayed phase where you don't sleep until later. Our sleep clinic, the one that we use, is similar in that they like you there at 8:30 and they'll hook you up to everything, but you don't have to go to sleep until you're ready. Well, that still would be a very long time for you if you're used to going to bed at 3 in the morning.
Right,
I mean, that's almost an entire day. So what I usually do if I had somebody who's really off of their typical schedule is, call over there and say, look, this person, doesn't normally go to bed until 3 a.m. Can we alter it a little bit so it's at least close to what their normal sleep schedule is like? Because like you said, I couldn't fall asleep at 4 in the afternoon. I mean, that's basically what we're asking you to do if we told you to go to bed at 9 and you're used to 3. So you can sort of make special requests, at least at the sleep clinic that we use, to try to get it to look like a more natural night for you. And it will affect, how long it takes you to go into REM sleep and that type of thing. So it's important to get a typical picture, I think.
Well, what can you do to make it more conducive for people to sleep? So that you mentioned one thing is, maybe you can do it later. I don't know. Do you play nature sounds, or do you have fans going, or like what? Has the clinic invested time and effort in trying to make it the most sleep-inducing environment possible?
First of all, it's really good to have great sleep techs, and there are a lot of them out there that make you feel really. And the ones at our clinic are fantastic. They make you feel really at home, and this sleep lab is set up, in a hotel. So it's a comfortable environment. It's not a sterile lab. I think that helps. We also try to encourage patients, bring your own pajamas, bring the blanket, bring things that make you feel at home, and routines that relax you at home. I tell patients, be as sleepy as you can. Go for an extra workout that day. Tire yourself out so that your brain, even though it might want to be vigilant, has to give it up eventually. So those are some things. And, sometimes I wish we could send everybody 2 nights in a row, because the second night's always going to give us better information than the first. But you do the little things that you can to make it as close to normal as possible.
You feel like you're getting good data because of the first night sleep effect, and because of
you do
the clinic being a foreign environment?
There are just some things that that's probably because of first night, but you still get a treasure trove of information from a sleep study. It's pretty impressive what you can get.
Is all this shared with the person? And, what are some things that maybe people wouldn't even think that you can learn from a sleep study that you guys learn?
Yeah, absolutely. Yes, they come back for follow-up, and we spend a lot of time going over the study in detail with them, showing them the different stages of the sleep. There's something called sleep architecture, which is how you pass through each stage of sleep and how much time you spend in each stage. So there's REM sleep, but then there's 3 stages of non-REM sleep, N1, N2, and 3, very creatively named. And N1 is very light sleep, N2 is deeper light sleep, and N3 is that, slow wave, delta, really deep sleep. So we can actually, because you're wearing those EEG leads and we're getting that brainwave activity, we can show you how you go through each stage, in what order. Is that normal? Do you have any awakenings when you're not supposed to out of slow wave? You should always pass through the gate of lighter sleep on the way out. And so we can look at all of that. We can see when you're dreaming and for how long. Most people, have shorter dream cycles in the first half of the night, longer dream cycles in the second half of the night toward the morning. So that's all pretty interesting. There's lots of respiratory data, obviously, 'cause one of the purposes of sleep studies too is to rule out sleep apnea. So we get to see your oxygen levels, how you're breathing during the night, if you have pauses and those types of things, heart rate. We can tell if you're having reflux, if you're having, things like that as well. So, and of course, they also look for odd behaviors at night. Are you acting out your dreams and things like that?
All right. I guess a couple quick things. Any urban myths or misconceptions people have that are super common about doing a sleep study or sleep in general?
Well, lots of urban myths about sleep in general. I mean, I think one of them is that everybody needs 8 hours. Sleep's very individualized. So, some people do fine on 6 and other people need 9. So I think in the media these days, it's easy just to generalize it or average it out, but that's all it is an average. So I think sometimes that can create problems for people who are really trying to get their 8 hours, and now they feel pressure to get their 8 hours or all these bad things are going to happen. And maybe they're a person that, it's fine on 6, and trying to get 8 just creates 2 hours of insomnia. And then there's frustration, and then it builds a problem that need not have been there to begin with. So I think that's one of the common misconceptions. But on the other hand, we have people that aren't giving themselves an ample opportunity to sleep. And that's a big problem too, because if you're working 2 jobs and you're up until, 3 in the morning, and then by the time you get home, you still need some me time. So you watch a couple of episodes of, something on Netflix, and then you got to get up and do it all over the next day. That's a really dangerous situation as well. You're not giving yourself that opportunity to sleep. So 2 different sides of the coin, and that's the interesting part of sleep medicine is we get to see both. We get to see, I can't sleep, and we get to see I can't wake up.
Well, very good. So what are some resources for listeners? Like not everyone's local to you and can go to the sleep clinic, but if people want to reach out and find out more, what's your suggestion?
Yeah, I mean, I would say if you're having an issue and you've talked to your primary care person about it, I mean, there's usually somewhere in your area a sleep specialist of some sort, and they're really good at doing a very thorough history and assessment, deciding if you need a study, what study is appropriate for you, and really diving into all of that information and being able to explain it to you. As far as narcolepsy is concerned, I would say resources from Narcolepsy are Narcolepsy Network, Wake Up Narcolepsy, Project Sleep, National Sleep Foundation, things like that, and finding your support group. There's Facebook support groups, there's local support groups, for people with narcolepsy that are really helpful, there. But yeah, seeing a sleep specialist is a great way to go. You'll get a good, thorough evaluation. They really know, kind of which direction to go with your complaints or your symptoms, and can give you a good evaluation and treatment and management.
Okay. Well, very good. Well, Ellen, I appreciate you coming on, and I learned a lot of interesting stuff. It's been a great call, and thank you.
Yeah, thank you so much for having me.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you.